rising subject in the world of dietetics. With coding, we're getting more reimbursement for malnutrition. Physicians are looking to dietitians to do the diagnosing process. And within all of that, there's the nutrition physical exam, understanding the coding. There's just so much. So tonight we're going to really talk about that so we can get Southwest Missouri Dietetic Association and all the members and people around here really familiar with malnutrition and really get our game on. Sound good? So a couple housekeeping things before we get started. I am going to pass around the sign-up sheet. If you are a student, please put student next to your name so I know you're a student. If you're a dietitian or a DTR, put RD or DTR next to your name also, please. So I will start passing around. CEU credits for everyone who is paid, and if you need to pay Amanda in the back with the blue waving her hand, please pay her. It'll be $10 per a CEU. If you're a student, obviously it's free, or you can listen to listen. We also have these to hand out. These are for free. Little My Plate SWMDA thingies to put on your fridge, anywhere that's magnetic. So I'm going to let Kyle and Catherine take it away. They're our first presentation.
All right. Well, thanks so much to the SWMDA board for having us. Really appreciate the opportunity. I'm going to move once, and I'll be done moving. Pass these around.
Maybe tell them that our interns has to take one.
Yeah, you guys actually, you don't need to put this for you guys. Can you actually Okay. Really appreciate the opportunity. Today we're going to talk about malnutrition, definitions, diagnosis, and documentation. So presenting with me will be Catherine Deneuer. She's the System Clinical Nutrition Manager through Cox Health. I've known Catherine a long time, and my name is Kyle Brashear, for those of you that don't know. I'm a faculty member at Cox College. And real quick, before I get started, so I can adjust as needed, if you're a student, can you raise your hand? All right. And so I rehearsed this, and I was a little over on time, so I'm going to rush through the slides a bit. So if you have any questions at all, I love talking about this. I'll be around. Feel free to ask me questions, email me anything. I really enjoy teaching and talking to people about malnutrition. So we have some objectives. First, we're going to identify the constituents of the various definitions of malnutrition. The main guidelines we're going to look at are the A&D Aspen characteristics to diagnose malnutrition, so hopefully you'll be able to understand, apply, and document those. We're going to identify some limitations of the A&D Aspen guidelines. We're going to perform and interpret hand grip strength using dynamometry. So we got some hospital beds, so after we're done presenting, we'll have some breakout sessions that you can participate in. And then part of that is performing and interpreting a global nutrition-focused physical exam. Okay, so the first question is, what is malnutrition? Right? So we've been studying nutrition for quite a while now. We should have this figured out. Well, there really is no consensus. There are a couple different issues. One is the actual definition of malnutrition. So asking the question, what is it? And then the second part to that is, after we know what it is, how do we diagnose it? And one thing in doing a little bit of research for this project, I noticed that sometimes our definitions and our criteria for diagnosis are congruent, and I think that's a really important part of the process. So part of the confusion comes from all of these malnutrition syndromes. And there are these other syndromes that are related to malnutrition that have lots of overlapping features that make it a little bit confusing. And examples of those: sarcopenia due to aging, sarcopenic obesity, precachexia, cachexia. Cachexia can be seen in cardiac, pulmonary, and cancer. They have what's called refractory cachexia, protein energy wasting. So this hairy diagram here is just referring to protein energy wasting, and that's focused on patients with kidney disease, frailty, PDN, marasmus, kwashiorkor. So all these are malnutrition syndromes, things that are similar, have overlapping features, and so it makes defining malnutrition very difficult. And each one of these actually can have their own set of criteria. For example, protein energy wasting, there is a very specific set of criteria that define this, and it kind of only applies to patients with kidney disease. So looking at some of the various definitions, some of them are intake-based. So the World Health Organization they say malnutrition is deficiencies, excesses, or imbalances in a person's intake of energy and or nutrients. And so that's pretty straightforward. Most other organizations take it a step further, and they say, well, it is about lack of intake, but we want this lack of intake to cause some sort of physiological change. And so SWMDA, they say undernutrition is a lack of intake, and it leads to changes in body composition, which they define as decreased fat-free mass or body cell mass, leading to diminished physical and mental function and impaired outcome from disease. And so, again, it's beyond just intake, it's about these physiological changes of that occur in malnutrition. And then, lastly, there's this talk about inflammation. And previously, inflammation was ignored, but SODERs, this was back in 2008, they really feel strongly that inflammation should be included in the definition of malnutrition. So they say that over or undernutrition plus inflammation leading to these changes of decreased function and changes to body composition. So again, there's a wide spectrum of definitions for malnutrition. So the next thing we need to think about is how do we diagnose? And many of you are students, so I'm not sure how much of this that you've received, but whenever I was a student and whenever I first started practice, the use of albumin was still being used. I remember a documentation specialist coming up to me and saying, hey, this patient's albumin is 2.5. I think he has malnutrition. Can you see him? And just, it's not really a validated tool anymore. We don't use this, but so we've come a long way just in the last 10 years for sure. And so thinking about diagnostic criteria, A&D and Aspen in 2012 put forth some characteristics, and it was a consensus paper written by just constituents of those organizations. And they characterized malnutrition, defining it, saying it has 6 characteristics. And those are energy intake, weight loss, loss of muscle mass, loss of subcutaneous fat, fluid accumulation, and then decreased hand grip strength. And so they're trying to characterize muscle function there. Aspen in 2015 came out with some different diagnostic criteria. They used consensus as well, polled their members, took expert opinion from the group, and basically are saying if the patient has a BMI of less than 18.5, that would be considered malnutrition. Or if they've had weight loss and their BMI is less than 20 or a fat-free mass index of less than 15. And so the A&D Aspen criteria is much more comprehensive and thorough, I believe. And if I had to choose between the two, I would certainly pick the A&D and Aspen guidelines. A&D is Academy for Nutrition and Dietetics. Aspen is the American Society of Parental and Enteral Nutrition. And then Aspen is the European Clinical Nutrition Group. Okay, so I won't talk about this long, but I just wanted to quickly show this model. This model was developed in the late 70s, and why I wanted to put it in this presentation is just to show that malnutrition doesn't happen overnight. So we're not healthy on Wednesday and then we're malnourished on Thursday. That malnutrition is this spectrum, and our body has this ability to adapt. We have reserves of particular nutrients. And then as the disease or the deficiency progresses, we see physiological alterations, physical signs and symptoms. Eventually we'll develop disease. Some of that is irreversible. And then ultimately we may die from that. And so it just really highlights the spectrum of malnutrition, and that we can't just say this patient has no malnutrition or they have malnutrition, that it is this continuum. So we need to think about that as we're seeing patients. And secondly, even in the late 70s, they talk about how these physiological states can influence nutrient requirements. And so thinking about diseases or inflammation and how that can have an impact on nutritional status. Okay, so I would say more than half of the room is students. And so if you don't have a lot of experience with diagnosing malnutrition, I would really get to know the A&D Aspen guidelines pretty well. And so from the handout, the first 2 pages, these are essentially the guidelines. And you can see the 6 clinical characteristics on the left-hand side. Energy intake, weight loss, loss of body fat, loss of muscle, fluid accumulation, and reduced grip strength. If if anyone doesn't have one, we have some more on the web. And so with the characteristics, it's hugely a leap in the right direction in terms of standardizing the diagnosis of malnutrition. It utilizes the 6 characteristics, as I just mentioned. It allows for the diagnosis of severe and non-severe. And they have kind of 3 different categories. And those categories are malnutrition in the context of acute illness, chronic illness, and social and environmental factors. And so why this is important is that it's considering inflammation to be a driver of malnutrition. I think that's hugely important. Okay, so we're going to talk a little bit about the guidelines. We're going to go through some specifics. But first, I just want to give some caveats and some limitations to the guidelines. They're based very loosely on evidence, and so that's not a good thing. It's a consensus, so that just means that it's a group of people that agree that this is how it should be. So it's not a validated tool. It has never been validated. I think they are working on some validation studies currently, but it is not validated by any means at this time. And a problem with that, there isn't really a gold standard to compare that to. So anytime if you look into research or you're interested in that and you wonder how you validate a clinical tool, you have to have a gold standard. And there isn't really a gold standard for malnutrition to compare this to. Another caveat or limitation is that the categories don't really align with the ICD-10 codes. Like as I mentioned before, we have malnutrition in the context of acute illness or chronic illness. Well, that isn't like an ICD-10 code. And so coders have to, there's some interpretation that has to go along and some, what they call like a crosswalk to kind of make that fit. Diagnosing malnutrition is difficult. If you think that it's really easy, you're probably maybe not doing the best job because it takes a lot of critical thinking and clinical reasoning. So to apply the guidelines is not that complicated and it's not difficult to do. But our patients are so complex in the hospital now that to really interpret these things and interpret them correctly is certainly a challenge. And so I want to discourage blind application of the guidelines. So like I said, it would be pretty easy to kind of look at the guidelines, see your patients, and then just however they fit in there, just do it that way. But I really encourage, and as you get experience and practice, is using those clinical reasoning skills and asking lots of good questions. So despite these, we need to know how to apply the guidelines to patients. And like I said before, they need to meet 2 of the 6 characteristics for a diagnosis of malnutrition. Okay, so got the handout. And so again, for the categories of malnutrition, there are 3. So we have acute illness or injury, chronic illness, and social environmental factors. And if you look on the 3rd page of the handout, I've given some examples. So acute illness, we're looking at things that would cause a severe inflammatory response. So things like burns, multi-trauma, critical illness. Chronic disease is more of a low-grade inflammatory response. So these are most of our patients that come into the hospital. They have multiple chronic diseases, cardiovascular disease, diabetes, obesity. All of these things have an inflammatory component to that, and so we need to be mindful of that, and that inflammatory component is a driver of malnutrition. And then lastly, and probably the least common that we see in the hospital at least, is social and environmental factors. And so this would be patients, it's kind of what we call pure starvation or marasmus. It isn't a disease per se, or an inflammatory disease that's causing that. It could be anorexia nervosa. It could be if you don't have access to food, if you're homeless, or maybe you have some sort of anatomical limitation, dysphagia, that sort of thing. All of those, you could argue, would fit into social and environmental factors. Okay, so why I wanted to bring this up is just, again, drive home the point that inflammation is catabolic and it is a significant driver of malnutrition. Okay, so the first one we're going to talk about is energy intake. And so to do this, we have to collect diet histories. And so hopefully you guys are doing that when you're seeing patients. So we have to talk to them, see what they're eating in a day, and essentially we review their diet history and compare that to what we think that they need. And so, for example, if we think patient's eating 1,000 calories a day and their estimated needs are 2,000 calories, you can do the math and they're meeting 50% of their estimated needs. And so the A&D Aspen guidelines put forth some criteria on what would be considered malnutrition. So severe malnutrition in the context of chronic disease, for example, chronic illness would be less than 75% of their estimated requirements for greater than 1 month. Again, with everything, there are lots of limitations to this. One, they're not thinking about protein, which a lot of the literature now, especially with sarcopenia and this disease-related malnutrition, inflammation-related malnutrition, protein is, they're thinking is more important than actual energy intake. 24-hour diet recalls are, one, difficult to obtain from patients in the hospital, and two, they're not terribly accurate. So just because you eat these things in one day does not mean that's a good representation of your overall diet. In research, they would have to do, at least for energy, would have to do at least 1 week of diet records for that to be accurate. Then lastly, estimation of needs can be accurate as well. There's lots of formulas out there. You have to make sure that you understand which formula is appropriate for the type of patient that you're seeing. Do you want to go on time?
No, you're good.
Okay.
You can go a little.
Weight. So here's the formula to calculate weight change. This hasn't changed in many, many years. Even the level of significance hasn't changed in many, many years. This, comes from articles, I think, in the 60s. So you essentially take their usual weight minus their actual weight divided by their usual weight, and that would be how much weight that they lost. And so as you refer to the standards, you can see what the cutoffs are for significant or severe weight loss. Some challenges with assessing weights, fluid status, something we deal with in the hospital. Lots of patients have edema, and so we need to make sure that we're considering a dry weight whenever using these calculations. Scale accuracies is almost a joke in the hospital. We get bed scales and staining scales, and the weights are very different many times. When we're considering weight loss, that doesn't really apply to patients that are chronically underweight, that aren't actively losing weight, but they're malnourished and they're underweight. So patients with a low BMI, for example. So the guidelines kind of ignore that patient population. And then the specific cutoffs they use, I think could be updated because there's lots of new research that kind of shows that even marginal amounts of weight loss is tied to poor outcomes in certain patient populations. So that's what we have for weight. And then biochemical, if we think about a biochemical assessment, we're looking at assessing the patient's laboratory values. And why this is useful is to assess for inflammation. So I've said that many times so far. And before I also said albumin is not recommended as a marker of nutritional status, but it is a marker of inflammation, however. And so don't ignore albumin. Pay close attention to it. It doesn't mean that they had malnutrition because their albumin is low, but you need to consider that because it's really telling you what's going on in their body. So albumin's what they call a negative acute phase reactant. So in an inflammatory state, our body does not produce as much albumin. And so it kind of gives us some insight to what's going on to the patient physiologically. Most, if not all, chronic diseases have at least some inflammatory component. Okay, so the next is clinical. And so as Lindsay said before we got started, we need to be assessing the patient's fat and muscle status. And so we need to be doing the nutrition-focused physical exam. And so it's a subjective assessment. And per the guidelines, it's graded well-nourished, mild to moderate, or severe. And that is on page 4, I believe. I've given you the guidelines of what constitutes well-nourished, what would constitute mild to moderate, what would be considered severe malnutrition in terms of fat wasting. And so this example, this is normal. They're looking at a triceps skin fold here. This is moderate, and this would be considered severe. And so again, it's very subjective, and really the only way you get good at it is just by doing it and seeing lots of patients and developing good clinical judgment on where they fit on the scale. But they do have some more objective criteria in these tables. Points to consider for fat loss. In the elderly, they have redistribution of fat, so it may look like they have wasting in their upper arms, but that's not necessarily the case. It's just moved, so it goes to the viscera. And then fat wasting is really not that sensitive to malnutrition in the obese. And so a patient that starts out severely obese, no matter how malnourished they become, they're still going to have excess adipose tissue. They're not going to have fat wasting. So the next is muscle loss. Again, it's a subjective assessment. Graded well-nourished. This is looking at the deltoid muscle. Nice curvature, no prominence of this bone. And mild to moderate would be considered this. There's some squaring of the shoulder, and this would be considered severe deltoid wasting, severe squaring of that. And lots of different sites that we can look at. Upper arms, lower body. Catherine will be demonstrating the exam later on. Points to consider, you have to think about if the patient has ever had any neurological diseases in the past. So if they've had a stroke, that's obviously going to cause muscle wasting, but that's due to lack of innervation. May be completely separate from malnutrition, spinal cord injuries, etc. Edema can mask signs of muscle wasting. And then lastly, sarcopenic obesity. And so sarcopenic obesity is these patients that they look normal, but underneath all of that adipose tissue is very, very little muscle mass. And it's very hard to detect this type of patient using the physical exam. They've discovered a lot of this by imaging studies. So patients that have had cancer and have had MRI scans, they have technologies now that can look at how much lean body mass they have, and they're discovering that just because you're obese doesn't mean that you're not malnourished. And so many of those patients have severe muscle wasting. It's just very difficult to detect visually. Marshmallow reference. Aspen also says using fluid accumulation as a diagnostic characteristic. There's some how you assess for edema. That's debatable. Some people disagree with that, but that's what it is. So lastly, and this is what we're going to do in our little breakout, is assess muscle function. And so malnutrition doesn't just affect mass. We don't just get smaller and we have muscle atrophy and fat loss, but it also impacts the way that muscles work. And so how strong are muscles, how much force we can use to contract something like this. And so Soder's in 2008 even takes it a step further and says, okay, well, it does impact muscle function, but it also impacts cognitive function. We don't think as well when we're malnourished. It also impacts immune function. We get sick more easily, more susceptible to colds, that sort of thing. And so when we are thinking about diagnosing malnutrition, we need to think about these other areas of function. So if the patient comes in, maybe they haven't lost weight and they don't look malnourished, but how's their activities of daily living? Are they able to do the things that they normally were able to do? Are they weak? Do they fatigue easy, have low performance? And so a way to measure this objectively is just to take a grip strength. And so it is correlated with malnutrition, and it has been shown to improve with nutritional intervention. And so even though a patient, they're weak now, with nutrition, we can improve that. So that's a very important concept. And then there's a cutoff debate. And so that's the last one. I'll show you how to use this in our breakout sessions, but there's some debate on what we should consider normal and abnormal, and I'll talk about that then. Lots of value to measuring muscle function. And this sarcopenic patient is going to be more sensitive than probably any other tool that we have in our toolbox. There's been so many patients that we've seen in the hospital that they eat fair, they show no signs of muscle wasting or fat wasting, they have lost no weight. On paper, they look great, but then when we do the grip strength, they have no muscle function at all. They can barely move the dial. And so these patients are malnourished and they can benefit from us. And so many times this is the only way that we can catch them. A couple of limitations. Again, there's no agreed upon cutoffs, and there's no guidelines regarding goal setting. So it's just because it's a little bit newer. We haven't figured a lot of things out, but the pros, the value of using this far outweighs any con that exists. Next steps. And so we need to think about other ways to assess body composition. Again, with this sarcopenic patient, many of the things that we use, they don't work for them. And so we need to think about other ways. And so what's really going on now, and this is kind of new in research, is they're using imaging. So they're taking CT scans, DEXA scans, using bioelectrical impedance to measure body composition, and then even ultrasounds. And dietitians are doing these things. Dietitians are doing bedside ultrasounds on these patients to see how much muscle that they have. And so be on the lookout for that. And if things start coming down the pipeline, don't be afraid to try to work on initiating some of these things in practice. And then for anthropometrics, these things have been around for a long time, but we just don't use them as much as we probably should. But looking at calf circumference, mid-arm muscle circumference, that sort of thing. And then obviously the elephant in the room is we're ignoring these micronutrient deficiencies. And so these patients, they come in not only with protein and calorie malnutrition, but also vitamin deficiencies as well. Okay, so I'm going to turn it over to Catherine, and she's going to talk a little bit about Cox Health's malnutrition program and the process that we went through to incorporate some of these guidelines into practice.
All right. Good evening, everybody. Great to see you all. We have a great turnout. I don't really think I need this mic. Can you all hear me pretty good? Okay, is it too much echo with that mic sort of in the background? We're good. Okay. So a little bit about our journey here at Cox Health. One of the first things we incorporated several years ago, I think it was around 2012, 2013, is we moved to a validated screening tool. So probably all of us, all of you in the room are probably familiar with, there's a couple out there. We happen to use the malnutrition screening tool here. We also revised our standards of care, several times, and that was a team effort, and that's sort of an ongoing effort. I'm sure at your institutions you're always kind of looking at your sort of internal standards of care, how you might identify particular high-risk patients or deal with particular high-risk conditions like folks that come into your ICUs, for example. A little bit of background to kind of update you. Most of, I think, our success is really related to a lot of people that are in this room and people that have come before us that have been in this room or in these different buildings that we work. So it's something that I think we've been very fortunate to be proactive with. Mentors that I can think of in my career include people like Mary Ann Huff. For those of you who may know her, she was, rocking a little pocket, her little pocket assessment tools, magnifier glass around her neck back in the late 90s. So, and we also use Dr. Mary Ann Kite's nutrition diagnostic processes here. We also, Jesse Bedke, he's with us and he's one of our managers in our department. And back in 2014, he started to kind of ask a lot of questions about where's the data? Where are we at with diagnosing malnutrition at Cox Health? And so we started collecting that data, and I'll talk more about that in a little bit. There's some challenges to collecting that data and just a lack of it. So that might be something that you're sort of working on in your institutions as well. And we'll talk about that. Okay, so again, as I mentioned, we're fortunate, I think, at Cox Health to be a little bit ahead of the curve. And again, that's because of the strength of our team, the interest that our staff has shown throughout this entire process about really embracing, improving our scope of practice and the level of care we provide to our patients. I mentioned we use a nutrition diagnostics approach, and again, that's the Dr. Mary Ann Kite. She's the founder of that process, and we have folks that have been trained in her residency program, Professor Williams with Cox College. Of course, as many of you know, as many of you are students of the program that are in here tonight, we have a master's in nutrition diagnostics dietetic internship through the Cox College. It is the only one of its kind in the country at this point. A little bit about nutrition diagnostics. I'm not going to go into all the details, but we collect data within the 5 axes of evidence. So again, this is not new to those of you that are practicing as dietitians. We look at anthropometrics, we look at a person's diet, diet history, their intake. We look at biochemical, medications, how do medications affect nutrition status. More specifically with what Dr. Kite and the diagnostic process does, we're a little more concerned about how those medications may negatively impact someone's nutrition status, specifically certain micronutrients. For example, PPIs causing, issues with absorption and levels for iron or B12, that type of thing. And of course, the big piece is the clinical exam, the nutrition-focused physical exam. So the other thing we had to do, one of our first steps, is to make sure that we work with our clinical staff on being competent in these processes. So we went through a credentialing process. Part of that is what we do initially for new folks that come on with us as dietitians, and then those of us that have been credentialed in the past, we re-credential every year. So that includes a process for credentialing in nutrition diagnostics itself, and then in nutrition physical exam. And we have sections on macronutrients, fat and muscle, and then we also do micronutrients. As Kyle alluded to, there's a lot more to come with the micronutrient pieces, but we definitely cover quite a bit. We focus most of ours at this point on oral, peri-oral lesions for micronutrient disturbances there. Of course, with expectations, I think it speaks to the level that our staff is at. We hold each other accountable. We try to really hold ourselves to that higher level of practice. We're fortunate in that we're preceptors for these interns that come through our program. We meet a lot of really interesting folks over the years. They bring a lot to the table. We hope to teach them new things as well. And I think that close relationship between the health system and the college really helps make both teams stronger, learn from each other. We also do a series of peer reviews within with our clinical dietitian team. We have expectations that we complete so many peer reviews and so many nutrition physical exam rounds every 4 months. And so what that is basically the physical exam rounds going in groups of 2 to 3, visiting with patients and sort of cross-checking each other to make sure that our skills are up to par, signing off on that and keeping records of making sure we're doing what we need to be doing. We also are fortunate to have several of our dietitians that are advanced level practitioners, whether that be, some of them of course have their masters, but then in addition we have folks that are credentialed in geriatrics, nutrition support, those types of things. So I think that helps bring a little bit more variety to our team. So when we went to go to apply the AND and ASPEN characteristics to our practice, what we really wanted to do here, Kyle already kind of covered a lot of the highlights about what the characteristics entail. But we wanted to kind of really emphasize that it's not just trying to fit your patient in one of those boxes or trying to make them fit, because as Kyle alluded to, that's difficult. This is not, the AND ASPEN characteristics are never meant to replace the nutrition care process. We still need to evaluate our patients and think critically about what they need. We did a lot of education with our clinical staff, and I'm not really just speaking about our dietitians here, but with our DTRs, the nurses, the physicians. A lot of our physicians and our administration were very supportive of these initiatives, very interested. We had a large group of physician champions, particularly in our hospitalist group. Amongst the dietitians then, things that we did initially when we were kind of rolling out the AND ASPEN criteria, we did a lot of journal clubs, a lot of case studies, discussing this amongst ourselves, trying to develop reference materials that we would have in our department to refer to. And we also did a lot of hand grip strength education. You're going to see just a small snippet of that tonight, but just educating and signing off on those skills. The other big piece that we needed to work on was incorporating the language, the AND ASPEN language of those diagnoses into our documentation, right? So we needed to change our electronic medical record, our power form. So I'm going to show you that next, a few screenshots. So we use Cerner here. Some of you might use Epic, or I'm not sure what everyone's using out there, but this is, I know it's a little hard to see, but we have on the far left there is kind of all the different sections of our power form. I just skipped to the sections that I think are going to be of most interest to you. So this is by no means our full nutrition assessment, but I skipped to the clinical nutrition piece. Kyle and I worked on this with our Cerner and SI3 team back in November of 2014. So since about that time, we've incorporated that into our health record. So with on this page, we go in and fill out anything that we observe with our patient in the course of the nutrition physical exam. So those top few with the tongue, the gums, lips, mucous membranes, those are going to be mostly micronutrient related, but they could also be protein calorie related as well. Skin, obviously, anything we're seeing, or if they have a pressure ulcer or some sort of non-healing wound or wound vac. The hair and the nails, in the interest of time, I'm not really covering the micronutrients. I want to focus a little bit more on the bottom there where we've developed the tables for the muscle status and the fat. And so what we did is, similar to the handout that you have that kind of goes through the different anatomical locations for muscle and subcutaneous fat wasting, we basically were able to, list each of those anatomical sites, and then on the other side there, listing if it's mild to moderate depletion or is it severe depletion. So again, in an effort to sort of hardwire that into our documentation and make that readily accessible. So that's the clinical page. This is kind of part of what we do with our problems and etiologies. I'm not going to go into detail on this. This is, again, the diagnostic codes that Dr. Kite uses that we use with her permission and through our program here. This page is kind of our summary page where we're trying to kind of capture the overall nutrition status. And again, what we did here is we built in the diagnosis for malnutrition here. So you can see it's severe and non-severe for each of those different categories: acute, chronic, social, environmental. And we try to kind of summarize that in that overall nutrition status box. The next page, I did the next drop down, which is the clinical characteristics or the evidence. So what is the supporting evidence for that malnutrition diagnosis? And that's where we list that. Of course, it's not as easy as just clicking this box. Within the body of the assessment that came before all those other categories that I didn't walk through with you is, the supporting evidence is within that documentation. So a little bit, we've all seen in the literature the incidence of hospitalized patients that most likely suffer from malnutrition is, somewhere between 30 and 50%. This is just a little bit of a snapshot from when we kind of started collecting the data for both of our larger campuses. So it's Cox Medical Center South and Cox Medical Center Branson that are represented here. And so I just kind of want to draw your attention more from like 2015 to October of 16. That's kind of when we were able to get a lot more consistent between what the providers are documenting in terms of malnutrition and what the dietitians are documenting and finding. So this is kind of one of the pieces of data that we started to collect, was just diagnosis rates overall, okay? And that's just one small piece of that. The next thing we wanted that Jesse started tracking, and again, a lot of this started back when he kind of got us off to a really excellent start on collecting this data, was what ICD-10, well at the time they were ICD-9, but now of course they're ICD-10, so I'm giving you the current codes here. What codes are we utilizing? So, we were finding that we were using a lot of the unspecified protein calorie malnutrition, the E46. We were using quite a bit of that in 2014 and 15. I'm really happy to say that we're not using that anymore. Through the education and the malnutrition program, we've been able to get the physicians and the dietitians to really focus in on either the severe or the moderate, the E43 or the E44. Because again, that unspecified, that's not very specific, hence the word unspecified. So there you have it. That's, of course, kwashiorkor. When this first started, kind of in its infancy, we had a few of those here and there, and we've been at 0% on that now for years. So that's good. You don't want that. That's not going to fly really in the United States unless you have a very unique circumstance. We're going to talk a little bit. Then the other data that I think you really need to sort of look at is what we refer to as like the match rates. And again, this is just trying to show, are we improving that consistency between what the provider and the dietitian are finding amongst the patients and documenting. So I really want to focus in more on with us. So when the dietitians when we're working with patients and we're diagnosing malnutrition, developing an appropriate plan of care, we want to make sure that that gets in front of the provider so that provider knows to include that in their documentation and get the right code for malnutrition. What we've seen, thankfully, is a steady increase in this part of the match rate since pretty much all of 2015 and into 2016, and these were based on fiscal years. So at the end of 16 in September, we were about 53% of the dietitians being the physician then matching that. And in October, we are at 57. And I think this will continue to get better and better. Obviously, 100% would be the goal, but that's not a very realistic goal. So I would think, 90% would be a good stretch there. There's a reason for why this improved. It had been as low as, in the 20% range in 2014 and 2015. So I'll talk a little bit about why we think we had some success with improving that match rate. And here's why. We communicated, we collaborated. Again, it's not just about the strength of our nutrition services team, but working with other teams throughout the entire health system. We had great physician champions. We had Dr. France, Dr. Romero, Dr. Ussery. We had down in Cox Medical Center, Branson. We had, help me out here, Brian. Dr. Klontz, thank you. We worked a lot with the clinical excellence committees throughout the system. Jesse and I did a lot of presentations with them just in the last year, and prior to that, Jesse had done quite a bit with them as well. We did the system-wide. For those of you that don't know, we're a 5-campus system currently, so that's a little bit of travel here and there. We work with our health information management teams, our clinical documentation improvement specialist nurses, and then we also have recently, work with a consultant company called DMNA. For those of you, you may have heard of them. And I'll talk a little bit more about their role in a minute. But the great thing is when they kind of came in, they were able to say, wow, keep up all this great work that you've done. And what we hope from them is that they're going to be able to help sort of add to the piece of the puzzle of the financial impact or the potential financial benefit that might be out there for us. So here's one of the big reasons I think that match rate improved with the providers picking up what the dietitians were saying. We went to the hospital at the provider's request. We presented at the steering committee for the system, and they granted clinical privileges to our dietitians within our system to add a diagnosis of malnutrition right into Cerner on our active diagnosis list. And so they specifically were talking about E43 and E44. So when we as clinicians find that, we go into a separate section in Cerner, we add that appropriate diagnosis, again, when it's appropriate, not willy-nilly, and then that flows in front of the provider, and then he or she can pick that up and put it into their documentation. Again, this wasn't done in a vacuum. We worked a lot with our IT. They have a physician leader in IT. Clinical nurse informaticists help develop these reports and get education out to our staff. We went live with that at the end of July of 2016. So again, I think that's why in September and October and in recent months we've seen an uptick in that match rate. Again, we did a lot of education, not just amongst the dietitians, but with other staff to kind of know where to find this and how to enter it. It was a little bit of a new thing for us. This is not, there is no other, let me make that clear. This is only for providers in our facility and at any facility I've ever heard of. So we're the only folks that are going in there, other than physical therapists, I believe at this time. It's pretty much physical therapists and dietitians that add their own diagnoses here. This is something that I continually monitor, evaluate, run reports, cross-check to make sure our documentation matches what we're putting in this diagnosis list. So the journey continues. it's ongoing. So the why here, I think, is what's really important to us as clinicians. We became dietitians not because of numbers on a page, hopefully, but because of trying to improve the health of that person that we're working with, whether that's on the other side of a desk, on the other side of a bed, whatever it is, whatever environment that you're working in, we want to make them better. We want to identify potential problems, identifying the malnutrition, so that we can intervene, right? So that we have the right intervention for them. If our interventions aren't appropriate, and they need to be appropriate and timely for the biggest benefit to that patient to improve their health. Other endpoints that we clearly look at and our organization is very interested in are things like decreasing length of stay, and discharge to home versus a facility. Those are very important pieces to the patient as well. And of course, we want to continue to add value to our services as dietitians. And at Jan's presentation, I'm sure we'll talk more about that. So I'm not going to go into great detail on the reimbursement piece. But as I'm sure you probably are aware, E43, the severe protein calorie malnutrition, is a major complication and comorbidity. So that MCC code has the potential to increase the weight of a DRG, which would then potentially lead to increased reimbursement. Revenue integrity, that department is another bunch of great people that we've gotten to know really well. Jesse and I have made a lot of friends there. I mean, really, they really do like us. And we really like them. They've really helped sort of embrace this. You know, we've worked a lot with people that aren't really clinicians. They're not necessarily nurses or dietitians or even therapists or providers, but they want to make things better for the patient too and improve it. So that's been exciting to see that evolve. And so they've worked on developing reports for us that we have, and we are just waiting on folks to develop a secure site for us so that we can upload those reports to that consultant that I mentioned earlier. And hopefully what the consultant's really going to help bring to the table is a piece of software that they have that can analyze how did that potential diagnosis, specifically E43, move a DRG for a particular patient or client. The next thing to show you about a little bit is we have some recommended readings and references, and then we kind of want to break out into the demonstration group. So again, I don't mean to cut you off, but I don't want to delay others' presentations. So I'll be around at the end too, like Kyle said, so if you have specific questions, I'd be happy to talk to you more. And I appreciate your attention. I'm going to do some physical exam, nutrition-focused physical exam, fat and muscle assessment over here, and then Kyle will be on this side with hand grip. So perhaps we can just sort of divide down the middle here. Maybe you all can go this way and you all this way to Kyle. And I know we have a lot of students in the group, a lot of our interns, so please come over, but maybe hang back and let other folks have a front row seat. Since you've had a front row seat to this process before. Is that good? You good? All right.